The following podcast is part of a certified educational activity titled MS Treatment Decisions Before, During, and After Pregnancy. Focus on the use of disease-modifying therapies, featuring Dr. Maria K. Houchins from Harvard Medical School and Brigham and Women's Hospital in Boston, Massachusetts. Access the entire activity and complete the post-test at peerview.com/MUD860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Welcome everyone, and thank you for joining us today for our program on discussion of MS treatment decisions before, during, and after pregnancy, with a focus on the use of disease-modifying therapies, but we will also discuss other related matters around issues of pregnancy, preconception, and postpartum care. My name is Maria Houchins. I'm an associate professor of neurology at Harvard Medical School. I'm a director of clinical care at the Brigham Multiple Sclerosis Center and also director of Women's Health Program there in Boston. Let's start then with current guidance and evidence. So we know that the proactive family planning is very important, not only in neurologic care and multiple sclerosis, but really throughout the medical field. It's important because we need to know whether our patients might be exposed to any therapeutics that could be detrimental to their developing fetus. We need to have these conversations before these therapeutics actually start, or at least so that the women understand when they need to be stopped in relationship to their family planning needs. It's also important for us as neurologists and as medical providers to at least have some basic understanding about contraceptive options that our patients might be using, the current recommendations about the general prenatal care, and specifically for this neurologic disease, we need to know how to control the disease pre-pregnancy and how to assess the risk of pregnancy and postpartum issues depending on this patient's MS circumstances and situation. It's always easiest for us to look at actual clinical cases to then put some concepts into real practical terms, and that's what we're going to start with today. So let's consider two patients. Both of them have recently been diagnosed with multiple sclerosis. So the first patient, let's call her Linda. She has mild to perhaps moderate illness. She's a 25-year-old Caucasian female. She just got married. She presented with multiple sclerosis just recently, within the last 3 months, and has right arm numbness and tingling and has some difficulty grasping with her right hand. So she does have some motor involvement at presentation as well. Following her marriage and all the excitement, she now comes back to you and says that she now has recurrence of some of the same symptoms. The MRI that was performed for evaluation purposes identified 4 T2 hyperintense white matter lesions. And let's compare this presentation to another patient. Let's call her Kyla. Kyla is a 31-year-old African-American woman. She has been pregnant previously. She has a 2-year-old child. During pregnancy, she had some numbness on the left side of her body, especially in the leg, and had some difficulty walking associated with it. She thought maybe this was weight gain related that happened in pregnancy and ignored it a little bit. Didn't really seek medical advice at that time. Now she presents with difficulty walking, recurrent leg numbness, some difficulty articulating words, and extreme fatigue. A brain MRI that was performed showed T2 lesions greater than 10, and also importantly showed 2 inflammatory gadolinium-enhancing lesions. So let's keep these 2 patients in mind because we'll return to them as we discuss some topics this morning. So what do we know? What are some guidelines that exist in terms of recommendations, practice patterns and general consensus about managing MS before, during, and after pregnancy. So different medical bodies as well as regulatory bodies had come up with some basic recommendations. There are also several publications in the peer-reviewed literature, one by Dr. Ruth Dobson in the UK that represents a consensus of the Association of British Neurologists around these issues. Patricia Coyle a year ago published evidence-based review by international experts, and there was also a recent publication that we were all involved with around the world that reflects more of a combined worldly, if you want, opinion on this subject. And that was published by an organization that's fairly recently formed called IWIMS, and that's International Women in Multiple Sclerosis. And this organization comprises female neurologists, neuroscientists, again, all throughout the world, that collaborate on subjects of importance such as this. So I will mention here the question of, rather the subject of one key question, right? So this is something very important, I think, and I believe that all of us in practice of medicine should think about this as we walk in the door where there is a young female patient of ours of reproductive age, really with any kind of disease, right? And so this one key question concept goes like this. You walk into the door, you sit down, you start a conversation about various subjects that you need to address, and then as part of this conversation, you ask your patient, do you have any plans for pregnancy in the next year? That's the question. That's it, very simple. Then the answer to that question could be one of three ways. The woman could say yes, she could say no, or she could say maybe. Also fairly simple. So if she says yes or maybe, then your subsequent discussion during that visit needs to center around possible exposures to pregnancy, management of her disease, anticipating possible pregnancy within a year, and also looking at all of the medications that she's exposed to, not only disease-modifying treatments, as the case might be in multiple sclerosis, but also symptomatic therapies, supplements, vitamins, anything that she might be on, and making sure that this is compatible with onset of pregnancy. And you'd also want to talk to her about what she really should be taking in anticipating pregnancy, right? So if you get yes or maybe, this is going to be the focus of your conversation. If you get a no, then your focus should probably shift to making sure that there's effective contraception in this couple, that she tries to optimize her illness as much as possible in anticipation, maybe sometime future pregnancy at some point in the next few years. So with this in mind, let's just briefly mention contraceptive use, what we know about that. And there's a slide further down that talks about this in a little bit more detail. So what we know is that there is no evidence of negative impact of any OCPs on multiple sclerosis. There are some studies that have been done in the past focusing on possible positive impact of estrogen supplementation or high-dose estrogen supplementation in particular on the disease stability in women with relapsing remitting multiple sclerosis. So there might be positive effect, there's certainly no negative effect, there could be no effect. So discussion of oral contraception is important in that lens for this patient population. And if you're collaborating with an OB/GYN, then the concept of longer-acting reversible methods are important to have, or is important to have. In terms of fertility and fetal development, so this question gets asked a lot, is my baby going to be quote-unquote normal? How are they going to develop because of my MS? So we don't currently have any evidence of MS having adverse effects on fetal development. We're not so sure about the effects of fertility. In fact, a paper that we recently published appears to suggest that there might be a increased risk of infertility in our patients. And we suspected that for a period of time now, based on some studies and publications that were done. But this, our project really focused on examining medical claims data all around the United States. And so the strength of that publication was in numbers. We really looked at all the MS patients, commercially insured ones, in the United States. And there appears to be a significantly higher levels of infertility in this patient population, which is very interesting. Another question that is often asked is about genetic risk. Is there a higher risk? Am I going to pass this on to my child? So this question needs to be addressed by a provider. Lifestyle, what can I do to minimize any problems in pregnancy and afterwards? So discussion of prenatal vitamins, folate, vitamin D supplementation, alcohol cessation, of course, with pregnancy, smoking cessation, eating well. The issues of ART, or assisted reproduction, is also an important one, because there have been publications in the last about 10 years or so suggesting that going through IVF protocols, if they fail, if a woman receives an ART treatment, especially IVF with the GnRH agonists or antagonists, and if successful pregnancy does not occur as a result of that treatment, she might in fact be at higher risk for having a MS exacerbation and an aftermath of a failed protocol. If that treatment is successful and pregnancy starts and continues, then there is no increased risk to this woman of having MS not be in control. Question about sexual dysfunction comes up either independently or in conjunction with difficulty conceiving. Because if a couple is not intimate, obviously it's impossible to start a family. So that can become a significant issue for couples who are trying to have a child and are not successful in doing so. And then, of course, a very important subject is DMT, washout, depending on the product. When do I need to stop? How do I stop? Do I need to taper something down? What's going to happen to my disease? And so on and so forth. So that's all of these are very important considerations. So this is a slide for you that will be in your information and handout that you'll receive after this program. And this really outlines in some detail the different contraceptive methods. As a neurologist, I would suggest that you have a general familiarity with this. You probably will not be the one prescribing these methods, but you might be asked a question, are these okay to take? Is it safe? Is it effective? And while you'll refer that patient to contraceptive counseling to their GYN provider, you still want to be able to say a few words about this. CDC within the last couple of years has issued some set of guidelines about contraceptive use in patients with multiple sclerosis, and we assisted them with that work, and it appears that it's quite safe. As we said a few minutes before, it's quite safe, and that concern can certainly be alleviated. So all the things that we typically do for our friends and family and other patients when they're anticipating pregnancy are also important to relate to and help our patients with MS successfully consider and comply with as well. These include, again, avoiding alcohol, smoking, sleep, a balanced diet. All of these also help, by the way, with fertility. So we know that smoking and alcohol consumption while trying to conceive can actually have a negative effect on successful conception. And more specific to women with MS is actually vitamin D supplementation in a prenatal period. So the general recommendation for all women with multiple sclerosis is at least 2,000 units of vitamin D supplementation daily, and the ideal blood levels of vitamin D should be somewhere between 45 and 85. This is general guidance. In pregnancy, vitamin D is consumed faster, so again, in consultation with obstetricians, you might want to recommend slightly higher daily supplementation to your patients. And of course, folic acid. And the risk of urinary tract infections is higher in MS patients in general, in MS women, and is also higher in pregnancy. And so the combination of two increased risks could result in higher overall risk for this population of patients. We know that in the postpartum period, those women who had more difficulty in terms of MS control typically are those who had problems with MS control before pregnancy. So how their disease has been within the year or two before pregnancy tends to predict how they're going to do afterwards. So it's important then to make sure that your patients with MS are as stable as possible. And by stable, I really want to make sure that they're what we call NEDA, N-E-D-A, or no evidence of disease activity for 1 to 2 years before they start trying to get pregnant. That means no relapses, no MRI changes, and no disability progression. I think that early referrals to reproductive endocrinology, to infertility specialists, are really important. So if you suspect that your patient has, complicated MS management program, is older, might have trouble with fertility, I think an early consultation with that service is really important preemptively. The definition of infertility by World Health Organization for those women who are under 35 states that they have to try have unprotected intercourse to try and get pregnant for 12 months unsuccessfully before they can be classified as infertile, and over the age of 35 it's a 6-month trial. For many of our patients, it's just not an option to be on no treatment sometimes and to keep trying for 12 months. So that's why I'm saying that it's important to proactively refer in case your patient needs to be seen and helped with assisted reproductive techniques. So what do we know then about some of the commonly used MS medications? We now have about 17 or 18 products on the market now, so we might not be able to go through every single product. But I think it's helpful to consider this in general, sort of as groups of drugs in terms of their safety. So some medications that we use commonly are in fact quite safe to be continued up until the time of actual conception and can be discontinued once the pregnancy test turns positive. And some really need to be stopped way ahead of time. So let's talk about this a little bit. So if your patient is taking dimethyl fumarate or similar products, monomethyl fumarate, diroximel fumarate, or any host of generic fumarates that are coming to market, because of very short half-life and very rapid washout of these drugs out of the body, and so far a lack of any concerning signal of any problems related specifically to these medications in pregnancy or fetal development, we do not need to wash these drugs out. And what I tell my patients is you can continue up until your pregnancy test turns positive. For some patients who are more concerned, they can stop right as they start trying to get pregnant as well, if they're not comfortable going up until the time that their pregnancy test turns positive. But there's certainly no need to wash these medications out for weeks or months ahead of time. So that's good to know. The other group of drugs that is known in combination as S1P receptor modulators include fingolimod, siponimod, and recently approved ozanimod. Depending on the product, the washout times are different and they're longer for 2 out of 3 of these drugs. That has to do with the longer half-life. So the half-life of fingolimod is about 2 weeks, just a bit under. And similar, maybe a day or 2 longer for ozanimod and slightly shorter for siponimod. Also with the fingolimod, there were some early reports of some malformations, especially cardiac malformations in the babies who were exposed. Now, I will say that in order to understand whether there is a true cause and effect between the drug exposure and any sort of fetal abnormality, you really need about 1,000 cases, right? So we do not have 1,000 cases for this drug. So there's maybe some signal, but there's certainly there's no certainty there. Nonetheless, the recommendation is, as you see here, to wash out 2 months for fingolimod, 3 months for ozanimod, and 10 days for siponimod. Cladribine is a medication that should be washed out for 6 months prior to pregnancy. Teriflunomide should be washed out for probably a year or so. However, a good thing about teriflunomide is that there is an accelerated elimination protocol. So if you do this 1 key question and your patient says, I'm really thinking about getting pregnant in the next year, in the next 3 months, whatever it is, you can suggest that they undergo rapid acceleration protocol. Then if you want to, you can check their serum teriflunomide levels. And as long as they're under 0.02 mg per liter, it's safe for them to start their pregnancy attempts. In terms of the first generation injectable treatments, glatiramer acetate or any of the interferons that are currently on the market, again, for those, half-life is very short. We do have thousands of cases for either glatiramer acetate or combined interferon exposures for early pregnancy patients, just because of how long these drugs have been on the market. And we can now safely say that there is no association between getting exposed to these products and any kind of problems for either mom or the baby in pregnancy or afterwards. So they can be safely continued up until the time of conception and stopped with pregnancy test. Some providers actually continue glatiramer acetate throughout pregnancy. I personally don't do that. I think one can if they're really concerned about their patient. You could argue that if somebody is really concerned about their patient, they probably would not be on glatiramer acetate, going into pregnancy. But in general, again, this could be a little bit of a personal preference for the neurologist and the patient. The issue with natalizumab is a bit more complicated. So natalizumab is a very effective treatment for multiple sclerosis, has been around for a long time. The difficulty with natalizumab, specifically in relationship to pregnancy and conception questions, is that once a patient stops natalizumab, if no other drug is started to replace natalizumab, which the case would be in pregnancy, of course, you wouldn't start somebody on another medication in pregnancy, there is a possibility of rebound effect, meaning that the disease can come back, and sometimes it comes back with a vengeance, and pregnancy doesn't seem to be protective against this unfortunate occurrence. So I think that if your patient is on natalizumab and want to get pregnant, I think you probably would be well advised to have a consultation by a provider who is particularly knowledgeable and interested in pregnancy management and MS, and specifically in the use of natalizumab and how to safely discontinue it and what could be done. And maybe sometimes that drug can even be restarted again in pregnancy if a relapse cannot be controlled, which unfortunately is the case in some patients. The other monoclonal antibodies that are currently in use, the recommendation for alemtuzumab is 4-month washout after last treatment. Before each treatment, so that would be prior to starting the cycle for year 1 and the cycle for year 2 with this drug, pregnancy test needs to be done. And in pregnancy, thyroid monitoring is required. As you know, with this drug, when somebody has received alemtuzumab, they need to have blood work checked every month, and that should continue throughout pregnancy, including thyroid monitoring. With the ocrelizumab as well as rituximab and rituximab-related generics, the label, and it's important to state that in the United States, the label recommends a 6-month washout. And in the European Union, unless they recently changed, the label recommends a 1-year washout after either ocrelizumab or rituximab administration. However, in practice, we're not waiting 6 months or 12 months after we treat somebody with ocrelizumab, and there are good reasons for that. So typically, the washout for ocrelizumab takes about 3 to 4 months. But what's interesting about this product is that, even if the mom is treated with ocrelizumab and then waits 2 months and gets pregnant right on cycle 3, ocrelizumab has no way to get into the fetal circulation until placenta is formed. Once placenta is formed, then there is actually an active transporter in the placenta that helps the drug cross from mom's circulation into the baby's circulation through that transporter. Up until that time, there is no ocrelizumab that enters the fetal circulation. And that is why I think it's very safe to tell your patient that they can start trying to get pregnant about 2 months after, the last ocrelizumab or rituximab treatment. And if they get successfully pregnant, by the time placenta is formed, there is no drug anymore circulating. So that's why this recommendation is here. For ofatumumab, the recently approved anti-CD20 subcutaneous treatment, the recommendation currently on label is 6 months, and the drug is really too new for me to be able to give you any reasonable alternative recommendations. So, hopefully if we do this again in a few months, in a year perhaps, then we'll have experience with how this medication is managed throughout pregnancy and in anticipation of pregnancy. So let's come back for a minute to our 2 patients that we've discussed earlier. So Linda, remember, was a healthier patient. She indicated that she's hoping to become pregnant, but is not just in a hurry quite yet. So that one key question, yes, maybe, no, she would be a maybe. And then she would be using contraception at the time that she comes to see you. Kyla's family planning timeline is different. Kyla is a sicker patient, right? That she's the one who had the first relapse in pregnancy. She's African American, which is a little bit worse prognostically. She has motor relapse and some dysarthria which again is a challenge in terms prognostically speaking, and she also has active MRI. So, but she, on the other hand, would really like for her son to have a sibling. So she would like to conceive as soon as possible, but she doesn't know if that, if that can be accomplished. She has MS, and she would take more of your time and more in-depth conversation at this point. So you really want her, though, to try to be more stable with her disease, to try to recover from that relapse if possible. And ideally, the next MRI you check, you'd really want that to not have any active lesions and sort of not have any new disease there. So you would talk to her about higher efficacy treatment options. You would talk to her about relapse risk and discontinuation, especially as related to natalizumab. And we didn't mention, but fingolimod, one of the S1P modulators, also can have some rebound effects upon discontinuation. So this would be a more involved and more complicated discussion with Kyla that you will have. So in terms of how do we summarize this information? So in terms of guidelines and recommendations, there are multiple sources available to help clinicians and patients with preconception and prenatal MS management, including how to select appropriate treatment, how to manage it, when to stop it, what to watch out for. Discussions of MS treatment protocols in the context of family planning should begin at diagnosis and continue throughout DMT selection, and ideally every time you see a patient. I know how difficult it is. We have all these other things we need to keep in mind, talk about DMT safety, new MRI, discuss the exam. There is a COVID-19 problem now, everybody's concerned. Level of stress is very high, and yet with all of this, I think that the family planning question, this one key question, is something that we need to remember to ask all of our patients when they come to see us on a regular basis. Factors to consider and discuss with patients when you choose disease-modifying treatment. Traditionally, when we think about the choice of DMT, we think about how effective it is, how well tolerated is it? Is it going to, have major adverse events for my patient that are not on par with how serious their illness is, right? So there's always risk-benefit conversation and also thinking that goes on in our head. How is it administered? Is it convenient? Is the patient going to be able to comply with monthly infusions or daily, twice-a-day meds, or whatever the situation might be for a particular drug? And the washout time should something happen, and it also should consider potential impact of accidental fetal exposure during infancy if these conversations do not take place. So let's talk a little bit now about the medical management of MS during and after pregnancy. Let's come back to Linda and Kyla, our two patients. So Linda decided to stop her interferon when she conceived. Her pregnancy is now nearing the end of the second trimester. She has no relapses. She has no issues with pregnancy. She's doing well, looking forward to having her baby. Kyla decided to start natalizumab in anticipation of pregnancy. She started it. She was doing well, got pregnant, and discontinued natalizumab also when she conceived. She is now nearing 17 weeks, so just at the beginning of her second trimester, and had another relapse, unfortunately. As we discussed, disease exacerbations after natalizumab discontinuation, 2 to 3 months afterwards, are very common. So now she's having a relapse, which is very similar to what she had prior to pregnancy, and needs to receive steroids. So a couple of words about the use of steroids in pregnancy. We try to avoid that up to about 10 weeks gestation if we can. If relapse is significant and you need to use them, then you should use them, of course. But if it can be avoided, it's better to wait. So at her point in pregnancy at 17 weeks, it's very safe to use steroids. We recommend that methylprednisolone in particular, or other forms of prednisolone formulation, need to be used rather than dexamethasone or betamethasone. So methylprednisolone really does not cross the placenta very much at all. Only about under 20% of it crosses the placenta and effectively treats the baby. The rest of it only treats the mom. As opposed to dexamethasone and betamethasone, both of which have active transporter mechanisms in the placenta, and very large dose that you give to mom also goes to the baby. So ideally we prefer to stay with the methyl formulations of steroids. Let's look at this graph. So for those of us who are interested in this general subject, we remember the PRIMS study. PRIMS study was the first study done in the late 1990s that looked at pregnancy outcomes in multiple sclerosis patients and multiple sclerosis outcomes in pregnant patients. So that study was the first to show that at the time of pregnancy, during pregnancy, especially in the second and third trimester, relapses go down. Relapse rate really goes down to half or less of what it was prior to the start of pregnancy. So our patients, most of them feel well when they're pregnant. Once they deliver, though, about 30% of patients develop a postpartum exacerbation of multiple sclerosis within the first 3 to 6 months. And we now know, having looked at some of the data at our center as well as across the centers, that it's not only the clinical relapse that the patients have, but they also have increased MRI activity. So you can call it a radiographic relapse too. So between the two, clinical and radiographic, many of our patients experience disease recrudescence in the postpartum period. You can see on this graph here on your slide that the study that was performed, again, using the claims data set in the United States a couple of years ago, that it's very nicely following the original PRIMS data that's now more than 20 years old. So it's always good to do a study and really confirm that both are likely accurate and report information that is true. So an important question then is, what do we do to protect our women from having this postpartum disease exacerbation? There are several things that can be done. The first one is restart treatment, of course. So many of our patients want to go right back on their treatment once they've delivered, or they want to change treatment and go back on something else, but they want to be treated right after they deliver their child. And that's one option. We have also many women who want to breastfeed their babies. And we know now that breastfeeding can be protective against postpartum exacerbation if it's exclusively done. So exclusive breastfeeding means that there is no supplementation of that baby. There is no formula given through the bottle, and mom breastfeeds the baby, with every feeding. So as long as that is the case, there is solid data that within the 2 to 3 months of exclusive breastfeeding, the risk of postpartum relapses go down. And so depending on how worried you are about your patient, Linda versus Kyla, you would recommend that this person goes right back on the treatment versus tries to breastfeed and then, resumes their DMT. There's not enough that we know so far about DMTs and breastfeeding. We know, though, that some of them are probably safe during lactation. There were 2 studies done on interferons, intramuscular interferon, and its presence in the breast milk is minuscule. The study was done over 10 years ago and is referenced now in patient discussions. There was a recent study that we did looking at a long-acting interferon, and that one also is not present in breast milk in high concentrations at all. So likely is also a safer way to go if you want to combine breastfeeding and treatment. Glatiramer acetate, there is no known transfer to breast milk with GA, so that's likely safe. Other DMTs are still a work in progress. There's some data that's emerging on rituximab and ocrelizumab, but I would say that the jury is still out on all the monoclonals, and orals are likely not safe to be on and breastfeed. What's the best way for us to really understand what's happening to our patients in real world, in real life, not retrospectively, but prospectively? And a good way to collect this data is through pregnancy registries. So every disease-modifying treatment has its own pregnancy registry that is associated with exposure to that particular pharmaceutical. And those are very important as well. They're worldwide. They're usually FDA or EMA mandated. And we can certainly derive a lot of information from that. It's also important, however, to have a non-pharmaceutical sponsored pregnancy registries that are disease state specific. They're not drug specific, but they're disease state specific. One such registry is present in the United States. We are doing this in New England. It encompasses all of the New England states. And we basically accept any patient with multiple sclerosis, regardless of whether they were treated, untreated. We take those patients who are trying to conceive, so we understand the conception attempts, infertility, fertility, the length of that whole situation, and then we take any patient who is currently pregnant. And I believe that this is a very good and a non-biased way to really collect this type of information. There are also multiple pregnancy registries in Europe. There's one in Sweden that's very good. There's one in Germany. Because of different health systems, it's a little bit easier to do a countrywide registry in some of the European countries. So let's come back and finalize our two cases that we started this conversation with, Linda and Kyla. They've now delivered their babies and they come back to you and they wonder, what do I do about breastfeeding? So Linda would really like to breastfeed her child. She wants to know what that means in terms of her MS care. For patients such as Linda, who is generally stable, whose pregnancy was uncomplicated, and who had no issues with delivery, no neurologic problems in the aftermath of the delivery, I believe that allowing that patient to exclusively breastfeed her child, and certainly explaining the difference between exclusive and non-exclusive breastfeeding and some protection that might be given by exclusive breastfeeding, is absolutely fine. Some women really prefer to not be on any disease-modifying treatments as they breastfeed, even if you tell them that it appears to be safe and it doesn't penetrate into the breast milk at all, which is okay. So I think we need to be respectful of those decisions while providing information. So Linda's case is relatively easy. Kyla's case is more challenging, as we've said all along. She had that relapse in pregnancy. She was treated with steroids, and now she's delivered her child, and she wonders, could she resume natalizumab and breastfeed, or would she just breastfeed, or would she just resume natalizumab? So it's a challenging situation, and we address this in clinic not infrequently. So even though I truly respect women's desire to breastfeed, we just don't know enough about natalizumab and breast milk. There was only a couple of case reports, I believe, that looked into penetration of this product into the breast milk, and in fact it does pass into the breast milk at fairly high concentrations. A couple of case reports, so we don't have many patients, so we really can't guide our patients in that decision making. In a patient such as Kyla, I would really worry that she's at high risk for postpartum relapse. So again, as much as I'd like to support her in her breastfeeding desire, my recommendation here probably would be that she needs to restart natalizumab and not breastfeed. And I would not put her on any less effective treatment at this point. And again, we don't know enough about the other monoclonal antibodies that would be more effective or equally effective as natalizumab is, to really say that if you start, infusion A or infusion B, you can breastfeed on that product. We can't really say that today, unfortunately. So for Kyla, as sad as it is, the option of breastfeeding is less likely to be exercised, and she probably should start on her disease-modifying treatment as soon as she can after she delivered that baby. We can spend a lot more time discussing the subject, but our time is up. I'm very grateful for your participation, and I'm hoping to see you on this or other platforms in the future. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/MUD860. This activity is supported by educational grants from Biogen, EMD Serono, and Sanofi Genzyme.